and welcome to CT News Junkie's second public policy forum. Today's forum is going to be on a public option, and on our panel here, we're going to have about a 45-minute discussion, and then we're going to leave 15 minutes at the end for questions. And everybody has note cards on their chairs, so if you have a question, please write it down, and Sarah's going to come around and collect it towards the end, and we will ask your questions at the end of the discussion. So I just want to open by welcoming. We have Senator Kevin Kelly, and we also have Ellen Andrews of the Connecticut Health Policy Project, and we have former State Representative Vickie Nardello. And we have Lynne Ide, the Director of Program and Policy at the Universal Healthcare Foundation. And on the end, we have Representative Sean Scanlon from Guilford. And I forgot to say Senator Kelly is from Shelton. So thank you guys all for making the trek up here today in the weather that was giving us some challenges this morning. So I just want to open by just kind of a discussion of what exactly, what is a public option, and a public option can be various things. It could be, it could be a Medicaid buy-in, for example. So, or it could be buying into Connecticut's state employee health insurance pool. So, if it's possible, maybe Representative Scanlon, can you tell us what Connecticut's insurance committee is looking at this year regarding public options?
Well, good morning, Christine. Thank you for having us on this panel. It's good to be with this great group and talking about a very, very important issue for the state of Connecticut, which is to improve the quality and affordability of healthcare and to give access to healthcare and improved access to healthcare. I hate to not give too many details away, but I'm going to save the suspense of what we're actually going to propose until March 7th, when we will unveil the bill and have the public hearing on the bill. But I will just say that we have spent the better part of a few months trying to look at all the different ways that we could actually do a public option, whether it would be on Medicaid, whether it be a Medicaid buy-in, whether it would be creating a whole new entity, whether it would be creating a public option on the exchange. And we looked at all these issues. We talked to national experts. We talked to folks here in the state of Connecticut. And I think that we did come up with the best possible plan in terms of meeting the goal, which was to help folks that are having a tough time affording insurance right now, and folks that are not able to access insurance, perhaps based on their immigration status. So I think we will be rolling out what I believe to be a pretty contemporary bill on the 7th to address both the cost of insurance on the small business side and on the individual side. And I look forward to having a conversation with that with my good friend Senator Kelly and the rest of the members of our committee after the 7th.
So, Senator Kelly, is there a public option that Connecticut's Republican Party can support?
Well, first, let me begin by thanking you for having the forum, and I concur with a lot of the statements from Representative Scanlon, who is chairman of the Insurance Committee. With regards to the public option, we got to keep in mind that the public option has a public component that can put the taxpayers ultimately at risk. So it would depend upon what it looks like. I think there is a reason why President Obama didn't include this in the Affordable Care Act. I think there's a reason why no state has adopted a public option. And for those reasons, I think we need to be really cautious. We welcome the conversation, but you got to look at what the problems are with the public option and what ultimately would occur as a result of it.
Ellen, is there anything, as far as public options are concerned, do you think that there's any room for Connecticut to go forward here in regards to how it expands the public option? Connecticut has the partnership plan, which is run by State Comptroller Kevin Lembo, has about $100 190,000 lives in it, and could they expand that to a certain population that doesn't carry necessarily the same risk?
Yes, I think it's definitely, well, I shouldn't say definitely doable. I don't know. I guess the answer is I don't know. I hope so, because I agree that people are looking for affordability. A little more competition in our market would be a good thing. It is, but I'm skeptical, I guess. The partnership right now where cities and towns buy into the state employee plan, for a single active employee right now, this year it's over $10,000. It's 10,000, I have it here somewhere. But anyway, it's a little over $10,000. Small businesses are paying on average closer to $7,200. That's with workers under 50. And still, half of them are not able to afford that. So it would have to come down by 25–30% just to come to where what they're already offered now. And to go below that, starts to get you worried about how much we're going to pay providers, what the provider panels are going to be, what's going to be covered, how many hoops you're going to have to go through, and the cost sharing, which, once you sort of toggle down on all those things, it stops looking like insurance.
Ms. Nardello, you were recently on the campaign trail. You ran for a state Senate seat. And so what did you hear from voters out there regarding health insurance? How important is this as a topic for Connecticut to tackle right now?
It's actually incredibly important, and one of the things that I did during my campaign, and I've always done, I do a great deal of door-to-door. So I actually talked to voters and thousands, literally, not hundreds, but thousands of voters. And two of the things that I heard almost exclusively as I was going through was the cost of health care, the concern that they might lose health care, or that health care might become unaffordable to them. And when I talked to small businesses, interestingly enough, they never stated that taxes were their biggest problem. They told me that healthcare and energy costs were their biggest problem, and healthcare being one of those prime cost drivers for small businesses. So I feel very strongly that Connecticut does need to address this. And there is clearly a desire in the public for a more affordable opportunity to get affordable healthcare, and healthcare provided to everyone. And I stated very clearly that I do think healthcare is a right, not a privilege. And I think that if you come from that perspective, you're going to look at this subject somewhat differently. Your underlying philosophy is going to make a difference as to how you approach the public option.
And Ms. Ide, your organization did a survey, and can you explain some of what they found out there regarding Connecticut and healthcare costs?
Thank you, Christine. The Universal Healthcare Foundation of Connecticut last year commissioned a statewide survey of voters with the support of the Alterum Institute's Healthcare Value Hub, which is a national nonpartisan organization. And the results showed that 50% of adults in the state of Connecticut experienced a problem with healthcare affordability in the past year, regardless of their insurance coverage status. And 43% of Connecticut adults delayed or did not get care due to cost. So cost is a big issue, but equally important to people is quality. We find in our work at the Universal Healthcare Foundation that a lot of people call us thinking that we're an insurance company and we're going to help them find coverage. And the stories that we hear over and over from people is that the current marketplace, the range of options, are not serving individuals and particularly small businesses well. And back to Representative Scanlon's statement that one of the goals of looking into a public option for Connecticut is that we do need to do more actively to meet the needs of the people who are being left behind in the current system. And that is small businesses individuals, people who experience the family glitch, individuals particularly who are over 400% of the federal poverty level and do not qualify for subsidies in the health insurance exchange. And I think it's a sad state when you go around and you talk to people around the state about health care and they are saying the same things that they were saying before the Affordable Care Act was passed. The Affordable Care Act went pretty far in addressing providing insurance for people who were uninsured, but the issues of affordability, access, quality, and choice still need more creative solutions here in this state. It is, I think, a travesty that our state hasn't stepped up to deal with this, and I'm very happy that we're going to be having this debate again. I do want to point out a point of history, that we did pass a public option, glide path to a public option in 2009, about 6 months before the Affordable Care Act was passed in this state, for a number of reasons. Namely, the Affordable Care Act was constructed in such a way that until 2017, states weren't really able to go back to the feds to go much further. And Governor Malloy at the time decided that he didn't really want to implement sustanet. So we have a history of studying this issue. We had many stakeholders involved in that work. In fact, 180 individuals from all different stakeholder groups were participating in the design issues around sustanet, which never came to fruition. I think, you know, almost 10 years later, it's time that the state step up and take a hard look at this and figure out what we can do to help people, because clearly the marketplace is not serving their needs.
So Representative Scanlon, 29% of the 109,000 people in the individual market on the exchange do not receive subsidies. So how are you able to target that population without eroding, you know, the private insurance companies that are in that individual market? How do you, I guess it's competition for them, but is that the population that you're going after?
Not necessarily. As Lynn said, the 400% and up is more of the target base of what we're looking at. And those are folks that don't necessarily, they can't get on the exchange right now. They make too much money to qualify for Medicaid, and they don't necessarily go on the exchange because they are paying for private or small group insurance policies on their own as private consumers or small businesses. And so we're not trying to compete with what Access Health is doing. I tell people all the time, the ACA did incredible things, but it did not necessarily do incredible things for this population base that we're talking about. And that's the folks that Vickie and Kevin and I talk to when we go out and knock on doors. And they sort of say, you know, I'm getting whaled by the cost of insurance, and I wish you could do something. And I recently, about 2 weeks ago, sent an email to my email list as a state rep asking for people to share their healthcare stories with me. And I thought that maybe, like all emails I send, I'd maybe get 5, 10 back. I, to date, have gotten over 100 emails from people. And these are stories that all of us can relate to because we've heard them all. It's our families, it's our neighbors, it's our loved ones. And I think by passing a public option in the state of Connecticut that is focused on addressing the needs of small businesses and small employees, there's about 700,000 people in our state that are employed by small businesses right now in the state of Connecticut. And most of those people are the ones that are struggling greater than anything else. My mom was a small business owner my entire life. She rarely had health care. And if she did, she was paying exorbitant prices for that health care. I was always covered, but she never was. And there's so many other people like that that are just struggling to either continue providing their employers with health care, which they want to do. Employers want to do that, but it becomes so expensive for them to do that. And then individuals who just are not getting insurance through their employer, but are maybe making too much money to qualify for subsidies on the exchange. So I think competition in healthcare and in life is a good thing. And I think by offering a public option structure in the way that we are going to do it, and we'll be announcing on the 7th, I think we found a way to not have these be in conflict with one another.
So Senator Kelly, does implementing a public option and changing the way people purchase insurance, does that lower the cost of healthcare for people across the board?
Well, first, I'd like to reiterate what many members on the panel have already said, which, when I walk door to door and when I meet people in public, we hear the same stories. And healthcare is an important issue and is an issue that not only myself, but members of our party also see as critically important to the citizens of Connecticut and to Connecticut's families. We agree that many of the promises of the Affordable Care Act, that it becomes affordable, we increase access and improve quality. Those are benchmarks and cornerstones to what we would like to see. And so as we move forward, what we want to make sure is that a lot of these issues are implemented in a bipartisan manner. The Affordable Care Act was rolled out and implemented not in that manner. But we believe that over the past few years, at least in the Senate, with Senators Fasano and Looney, there have been a number of bipartisan initiatives that have looked at healthcare to address these issues. Now, we know that the Affordable Care Act had a lot of promises that people want to keep the coverage of pre-existing conditions up to 26, caps on copays and deductibles that we believe are important and we'd like to see remain and consistent. And we've done that and embedded many of those principles here in Connecticut law. I think where we saw a failure was in the federal government funding and reinsuring the insurance. And so premiums, as we hear these statistics of 50% of individuals, adult individuals, can't afford it or having a problem affording it, 43% have delayed coverage. It's because of that affordability factor. And what we need to do is come to the table, and this is one issue that we can look at. I think we have to look at everything. Everything needs to be on the table. But what we need to make sure is that we don't destabilize the market in the manner in which we move forward, and that we don't put other programs that we believe to be equally as important, Medicaid, for instance, to put Medicaid at risk by putting taxpayers at risk and reducing money to the general fund. So these are important issues, and premium is part of that component. But with the medical loss ratio, we also have 80% on the other side of this ledger, which is the cost and the cost drivers. And I'm happy to say that Representative Scanlon led the charge with regards to the prescription drug transparency bill, where we got a number of stakeholders together to start to look at that, because that's the primary and principal driver in the economy, in the healthcare arena. And we've got to get our arms around those issues too, but we welcome the conversation and we look forward to the dialogue.
So, Ellen, you've been around this debate for a long time. Can you kind of remind us, Connecticut did have this Charter Oak Plan, which was actually started by former Governor Rell in 2008, maybe? No, 2000, before that, 2008. So this was before the Affordable Care Act. Right. So what kind of lessons might we be able to learn from that experience, in which what happened with this pool of people was that a bunch of sicker people joined because they wanted insurance?
Right. I think you answered the question, yeah. It was an add-on to managed care in 2008, and it went through about 2013. It started with premiums of $247 a month, and it ended in a death spiral with over 500, almost more than twice that, because a lot of people with serious health problems signed up, which isn't really surprising. The Medicaid is built, Medicaid's different. I can't say this in enough places. Medicaid is unique. One of the ways you get into Medicaid is by having high medical bills. It is for people who are low income, people who don't always speak English, very high mental health, HIV. It's a safety net program. It is meant for people who are the most fragile. So the panel reflects that. And so it does attract, it did attract in Charter Oak people who had high medical bills, and it ended in a death spiral. Now, that was at a time when our uninsured rate in 2013 was 9.4%. It's about half that now. It's 5.5. So we're looking at a pool of about half as many people who would be interested. In some of the other states that are looking at this and very excited about it, like New Mexico, their uninsured rate, I looked this up. I looked it up, can I find it? They're over 9% right now. So I get why they're looking at this. Ours is low. It did go up last year, unfortunately, and interestingly, it went up fastest for people with household incomes over $100,000. It's those people who don't get subsidies, who aren't getting help, who are seeing the crunch. And we do need to help them. I agree with that. But I do have concerns about Medicaid as a base for it. And there are things we can do differently than we did with Charter Oak. But, you know, Medicaid is in such a good place. I hate to be too defensive. Like, don't screw with it, please.
Well, so there was a lot of news today from other states in which their Medicaid expenses are driving their budget deficits, and that's actually not the case in Connecticut.
Connecticut, we are saving since 2012 almost $1 billion a year. We used to be 9th highest in the country. We're now 20. Thank you so much for
You're welcome.
These come. We're now 22nd. We have improved access. We got 32% more providers in the program. People are not going into the hospital, they're getting into primary care. When I sit down with a client, I usually now have a choice of a place for them to choose to go for as a new patient. I used to like be on the phone begging. You could never find somebody to take them. That's no longer true. And Massachusetts looked at a public option last year. They did a study, and they decided not to do it. They rejected it. And Massachusetts is more like us than New Mexico because they have a even lower than ours, uninsured rate. And they decided that the costs to the state were too high, and the liability was too scary. And they were also concerned, to Senator Kelly's point, about disrupting the market we have. You know, Medicaid covers 840,000 people, and it's not perfect. I will, you know, I don't want I'm still going to be lobbying all session for improvements to the program, but it is a lot better than it was. We don't want to do anything to jeopardize that for potentially a few thousand people.
So Vickie, on the outside, you know, outside of the legislature looking in, how would you, if you were a lawmaker, how would you be pushing to structure a public option or structure a more affordable healthcare plan?
Well, I think one of the biggest issues that we haven't addressed yet is the fact that if you look everywhere across the world, healthcare is universal. So the benefits of universality are the fact that you now have a very large pool of people. You have healthy people and non-healthy people who are in the pool, and therefore the healthy people support the non-healthy people. So when you are structuring a public option, and I do believe we can still do it if it's structured properly, you have to make sure that you are looking at that it's financially solvent, okay, self-sustainable if you're going to do it in that manner. Okay, that's one way to do it. So it would be self-sustainable, paid for through premiums. The other way that you could do it is that you would obviously have to have tax subsidies. The other issue for me is affordability. Okay, is the person in the program going to be able to afford the premiums? Now, when Ellen talked about Charter Oak, when it became $500, that was really a break point, and it had to do with the fact that you had a lot of sick people. So that goes to my first point about the fact that you need a large pool of people in order to do this. I'm not as concerned about the competitiveness and the destabilization, because my feeling is that if you are a believer, an underlying believer that healthcare is a right, then what you want is the most affordable plan that gives the most coverage to the most, you know, to all people. So everybody has a right to health insurance. So therefore, if that ends up being the public option, if you structure it in a way that it does that, then you in effect will have benefited society in a way that's a goal that I would ascribe to. Okay, The other thing about the public option that people don't think about is that it has portability, okay? And one of the real problems, I taught healthcare policy for 3 years, okay, as an adjunct, and one of the things that people don't realize is that we don't have portability in this country in our healthcare system, and therefore that is actually a disadvantage to employers, okay? And it's a disadvantage to the individual, because first of all, employers now are responsible for all the healthcare costs if they were in an employer-based system. And the individual, if they lose their job, loses their health insurance. There's really virtually all of the healthcare systems in the world don't have that. They achieve that through different goals, by the way. There's various ways to do that. But the fact of the matter is that they do have that. So I think that the critical thing here is how you structure that public option, and that's going to go to Representative Scanlon. I'm hoping that, you know, the research is there, the tried and true method, and the willingness. I think one of the ways Connecticut, looking now outside as a legislator, having been out of the legislature, is one of the mistakes that we often make in Connecticut is we pass something and we don't go in and modify it and look at it to say, is it working? Can we tweak it? Or do we have to actually get rid of it altogether? Okay? And sometimes we can just tweak things and make them work really well. So I hope it's incumbent upon you, Representative Scanlon, to make sure that once this is done, you don't just say, okay, we're done now, I can go on to the next thing, which is what happens in the legislature. Let's look at it, let's see if it's working. Let's work with our Republican colleagues, I don't have a problem with that, and say, where can the tweaks be? But we aren't going to know until we actually do it, and I do believe we need to try it to find out.
What about, do we need an individual mandate in order to get there? I don't know.
We actually don't believe you need an individual mandate because we believe that people want health insurance. I mean, it's been shown when the mandate was removed at the federal level, there was some drop off, but still people who need care clamor to get coverage one way or another. I don't think that's what we should be basing this off of. One thing that we talked about previously, about 10 years ago, was not an individual mandate, but automatic enrollment, so that if you showed up at some place to get care and you didn't have care, you would be enrolled unless you affirmatively declined being enrolled in the public plan. So I think there are all sorts of different ways you can approach it, but one thing for sure, I agree with what Vickie Nardello said, that we need to endeavor to get there, and I appreciate what Senator Kelly has said about the interest in bipartisan support for creative solutions. I think we've learned some things in the past 10 years. We've learned from Charter Oak. We've learned from the implementation of the Affordable Care Act. We've learned what is working and what is not working. And now it is time for us to take a step into the next phase of healthcare policy in the state of Connecticut and have the state step in and use its leverage and bargaining power to help out the people who we have learned are not being served effectively by the current structure of things. We need to shake it up a little and get there. I mean, it's not going to be the panacea for dealing with costs. The cost drivers in the system are pharmaceutical costs, hospital costs, and premiums for the consumer. And there's bipartisan support on this issue. The survey that I referred to earlier on showed that 81% of the people polled in the state believe that drug companies are driving up costs. 74% believe that hospitals are charging too much money. And as we've consolidated the health provider market in the state, that's provided them with more ability to charge more money with not necessarily better outcomes. And insurance companies are charging too much money, 74% of the people said. But 80% of the people across party lines believe that the government needs to do something to step in and help them out.
So, Representative Scanlon, would a public option erode employer-sponsored coverage?
No, I don't think so. I will answer that, but I want to touch on something that Vickie and Kevin said. The most frustrating part about this job that I have, that I've had for 2 years, is that you love to think of check the box and move on. It's politically appealing to do that, to have a press release and a press conference and say, we solved the healthcare crisis by passing this one bill. But those of us who are actually in this building and those who watch this building closely know that that's not the case. And you know, Kevin and I are from different parties, but he's a very good friend of mine, and we have a great relationship, and I value his opinion more than a lot of Democrats in this building. And we work on stuff closely together, and I hope that'll be the case for not just the public option bill, but every other bill that we do this year to try and lower the cost for folks. That's been my goal since I took this job, is to lower costs, improve quality, expand access. Those are the three things that I always think about when I look at any of these bills. And that doesn't mean that it's got to be a Democrat bill or a Republican bill. It's just a bill, and is it good policy? Does it meet those standards?
How many initiatives do we have this year that are bipartisan to lower cost? I mean, lower drug costs, lower medical costs.
Well, so we have the public option bill. We have another prescription drug bill this year that's going to be rolled out on the 28th. Kevin and I have had many conversations about the concept of reinsurance. That's something that we should approach here in the state of Connecticut, and we will hear that bill in a bit. There's a number of things that I think we can talk about, and then, like everything else, we have to have a conversation. We'll have the public hearings, we'll screen the bills, we'll talk about this. Yeah, we may disagree on some things, but I think at the end of the day, at least in the last 2 years, you know, Kevin was a co-chair last year, now he's not, but one of the first things I said to him was I don't want that to change the relationship that we have, and I hope that it hasn't so far, and at least in my mind it hasn't. So, to answer your question, look, if there's 700,000 employees that are out there, and let's say that we did open up the state employee plan for them to purchase insurance through that, there's about 190,000, 200,000 people, lives that are covered on that plan. Even if half of them, or a third of them, went into that still leaves an incredibly large small group market that would still be able to access insurance through the private market, the private sector. We are having a big debate as a Democratic Party right now about the future of the insurance industry when it comes to things like Medicare for all. This is not about that. That's a national discussion that's going on. Right here in Connecticut, we're not talking about ending the private insurance industry. I certainly don't want to do that. It's a very important industry to our state, and they contribute a lot, and they will continue doing that. And there's a lot of folks out there that might not want to participate in a public option, but for those that are getting hammered right now by the cost of the insurance that keeps going up and up and up, the folks that Lynne is talking about, they want an option, and that's why we're having a conversation about how we can give that to them in a responsible way that does not infringe on any other programs that are out there helping individuals right now.
So, I think people are confused sometimes when people talk about a public option, whether it's, you know, the government might be the payer or the sponsor, but is not necessarily actually the health insurer. So in Connecticut's public option, aside from expanding the state employees pool, if you were going to do a public option, would an insurance company be the one actually administrating, or would the state be the one to backstop that?
And that's been a big conversation that we've been having, and I hate to, I hate to be so coy about this, but you know, that was one of the big things that we looked at, right? Is how do you do that? And I think the state employee, if we're talking about just the small, you know, the state employee plan right now, you have private insurance that is administering that program. The comptroller's office goes out to bid. Different private insurers bid on that contract. One is awarded that contract, and then they oversee and administer that plan. So I think that is certainly an option that we will be looking at, and I think that's one of the reasons why we're looking at specifically maybe doing something along those lines, so that it does not infringe and doesn't get into some of the problems that Ellen was talking about with Medicaid earlier. So
Senator Kelly, does a public option that would actually be the expansion of the state employees pool that would be offered by a private health insurance company would administer that? Is that a bridge too far to something like single payer?
Well, thank you. Well, single payer and public option are a little bit different.
Right.
Medicare Medicaid is a single payer. When we start looking at the state employee plan, obviously the devil will be in the details. First and foremost, when you start bringing small employers into the group, you got to be concerned about ERISA issues and whether or not the plan will continue to comply with ERISA protections. The other is that the experience of the partnership has been that benefits have exceeded premium. Right now they're running at about 105%. And what it's projected out is that they're looking at maybe 7 to 8% increases in premium when the costs are going to, the trend in the cost is going to drastically exceed those amounts. And the question becomes who picks up that delta. And that's where the taxpayers are on the hook, which makes it an unfair competitor to the private insurance market. So we got to look at this and have that discussion. You know, as Representative Scanlon had indicated before, it's all in the discussion. I think we need all the voices at the table. I'm looking forward to it, but we have to be concerned because those types of issues would destabilize and become disruptive in the insurance market. And getting back to, in order to make sure that insurance is affordable, you have to make sure that there is a product there to purchase and that it is at a price point that families can afford. I mean, I think that's the biggest issue we hear across the board is that families can't afford it. And it doesn't matter. This doesn't just visit certain families. It visits every family. And it's why it's such an important issue and why we have to address it. And, you know, we are Connecticut. We have the best and the brightest in both the healthcare and the insurance areas, and we can put them together and hopefully come up with a solution to the issues that families, not only in Connecticut, but maybe even across the country, are experiencing.
So let me just expand on that for a second. So would you be in favor of passing legislation that asks the insurance department to consider affordability when setting rates?
Well, we need to, you know, once again, it's what does the insurance and the Department of Insurance do? And they're looking at the viability of an insurance
Right now
carrier,
they can't look at affordability.
They aren't looking at that issue. I think what we need to do is not just, you know, check off the box. Well, now we have that and we've gotten through. So when people go to a public hearing before the department, they can be heard. I think we have to look at this holistically. It's not an easy proposition. It's not a one box and you're done. You got to look at, yes, insurance, but you also have to look at the providers and capping costs. You have to look at things. Ellen mentioned hospitals. We know that the ER room is one of the highest Medicaid appropriations, and there are people that are revisiting emergency room time and time again. That also needs to be part of the conversation, is how do we address that? I do have a bill in that would embed in hospitals a social worker or social worker type of individual who could then maybe look at not just the solution as a medical model, but a social model, and help the individual to get the services that they need so that they are diverted away from an emergency room where we spend the most expensive Medicaid dollar. It's initiatives like that, looking at every phase and breaking down silos and getting these services and programs level. That's what I think we need to be doing here under the Capitol Dome, and look at it in that manner.
So Ellen, should affordability be something that the insurance department looks to regulate?
Yes. Yes, that's an easy one. But I don't want to sound like I'm raining on the public option parade too much. That'll be for the hearing, I guess. But I think even if if it could work as well as, you know, as possible, it's not a silver bullet. I think Ted Doolittle said that at the forum. It's not going to solve the problem. And I think, I love the bill. I need to find the number. I need to testify on that. Thank you. But we need to do things like Senator Scanlon did take leadership in looking at drug costs, but we need to do more. Transparency is great, so we know how much we're getting fleeced. How do we stop it? And the cabinet actually had a whole set of recommendations to move forward from that, which I think that everybody should revisit. Also, there are outside tools that are becoming available. ICER, the Institute for Clinical and Economic Review, it's a nonprofit because lobbyists wouldn't let the federal government do this, is going to be looking at all new drug prices and saying which ones are supportable based on clinical evidence and which ones aren't. And I think we should be using that as a tool. Medicare is, Medicaid is, the VA is, lots of health plans, PBMs are using it. Why isn't the state of Connecticut using that kind of a tool to help us negotiate and make sure we're getting what we're paying for? There are proven public health initiatives like putting social workers in an emergency room. Love, love, love the idea. The governor's budget included a diabetes program that is evidence-based, CDC approved, to help people with pre-diabetes or with diabetes to change their lifestyle and maybe get off of insulin, which is like crazy expensive right now. Those are things we can do that help people and also save money. We also need to stop, there's a lot of low-value care that is being given that we don't need. We are being overtreated. How many people have been in a, you know, you're in the doctor's sitting on that stupid cold little bench and you're in your paper Johnny, right? And they say, I can't find your blood work. Just to be safe, we'll do it again. You know, that happens all the time. We are duplicating things and it's not good for us. It's expensive. We need to health information exchange so that that doesn't happen. And we also need to be thinking about what we don't need in terms of surgeries, knee and back surgeries. People are often not any better off and get back to work. It takes longer to get back to work after some of these surgeries. We shouldn't be doing them. You don't need an antibiotic for a cold. I say that as I'm coughing to death, but there are a lot of things we can do that bring down the foundational cost, which should put pressure on premiums to make those come down as well. Healthcare is, the health insurance market is not a clean market. When you go to buy a car, you know what you want. I know whether I want nice seats and a sunroof, and I know what value that has for me. I don't know what value healthcare has for me. I can't find a price to anything, and you can't find quality information on anything. So to expect the market, this dysfunctional market, to put some more competition into a dysfunctional market, and that's going to solve everything, is just not realistic.
So we have reached the point where we have 15 minutes left. So if you have a question, please put it on a card, and somebody will bring those up to me, or I will run out and grab them and read those. But in the meantime, so what should the benefits be if we have a public option? What should be covered with the public option plan?
I think
Lynn's jumping in.
I'll step up. I think that's a point for discussion. One of the things that really needs to happen is a really thorough process about plan design and what is covered and how you get to provide quality care at an affordable price. And so I don't think it's fair right now to ask what things should and shouldn't be covered. Of course, the 10 essential health benefits should be covered, and that was codified in state law. So I don't think anybody who is a proponent of this public option discussion and coming up with it as part of the response to what we're dealing with in our healthcare market would say that we want to be offering people, and excuse my lingo here, crappy plans. Nobody wants to be offering people a crappy plan at a price they can afford that isn't going to cover the care that they need when they are sick. So I think there are lots of different ways we can take a look at plan design to create an option that will work for the most people in the most effective way. I don't know whether you agree with that, Representative Scanlon? And also I'd like to concur with some of the remarks that have been made that public option isn't going to be the solution to the affordability issue. It has to be, affordability has to be addressed across the board in lots of different ways, and we need to be much more aggressive about it at the state level.
So we have 3 questions here, and I'm just going to open this up to anybody. How do we make sure that we do not harm, or we do no harm to our successful fee-for-service Medicaid program run without capitated insurers and saving hundreds of millions through avoided administration cost? I wonder who asked that question. Anyone?
We're opening up a conversation with whatever we see in this bill that comes out on March 7th. And I think that I will just say from the Foundation's point of view that we believe in the Medicaid program that we have in our state, and we understand how hard advocates and activists have worked to make it the plan that it is today, and I don't think I can just speak for ourselves. We don't have any intention of trying to undo that.
Go ahead. Yeah.
But that said, I think there is room for improvement in the Medicaid experience because coverage is one thing, but dealing with DSS is quite another thing. And while we've invested millions of dollars in new computers and phone systems, the experience is anything but an Amazon Prime experience. And in this day and age, with the technology that we have and the advancements that have been made, there should be more of a human element coming out of DSS to the people that we serve, so that their wait time isn't 2 or 3 hours to be able to ask one question, that you can get through to an actual person, that you do have a caseworker, and that they are responsive to your needs. So I think that's a component here that has to be addressed and dealt with also.
So you've been to the line outside DSS offices?
Yes, and I've actually called and had the phone pick up and hang up after 2 hours.
Oh my God. So could we talk a little bit more about the underlying cost? How do we start to lower hospital cost without messing with physician reimbursement? Can the state use other mechanisms to negotiate a lower cost?
I think overall costs on the healthcare system need to be addressed, and I think Ellen began to touch on them. The first is drug costs. Okay, when we look at drug costs, we're not doing the bulk purchasing that we need to do. We're not negotiating for prices. And one of the things that often isn't talked about is the fact that if you look at other countries around the world, they don't necessarily pay for drugs, who, when they are brought out new, are really virtually the same as an old drug and do not have benefit. They're much more expensive, and they don't have proven clinical benefit. And we need to rethink that in terms of the way we structure the way we pay for drugs. In addition to that, I think the other thing that, again, is probably paramount in other systems and works well is the fact that they fund primary care. We do not fund primary care here or to the degree that we should. If you have a very robust and healthy primary care system, the more primary care doctors that you have, the less healthcare costs you have, because first of all, they intervene at an earlier time. They educate patients. There are just so many reasons why we have to promote primary care in the States, which again, in other countries, they do better than we do. In addition to that, I just had my mother in the hospital. It was an interesting experience. She haven't had anybody in my family there since 2010, but this past October, my mother was in the hospital. And of course, I was her advocate while she was there. And I have to tell you, the two things that I noticed, and I knew this to be true from my own work, but I really saw it, was the fact that the communication among healthcare providers is really a problem. You have shift changes, you have the hospitals, you have various specialists, you have all these people. They are not talking to each other. Okay, so the result of their not talking to each other and communicating well is there is a duplication of efforts, there is care that may or may not be necessary, and the patient isn't attended to in the way that they should. The other thing that I saw is that if you don't have an advocate in the hospital system, okay, you're really in big trouble. I know a cardiologist who just was in the hospital as well and said they had a healthcare advocate the entire time they were in the hospital. Now, that really struck me because I thought, okay, here's someone who knows the system well. So that I think that we need to look at that in terms, like I said, our communication within the system and cost duplication and unnecessary services. All of these things will help to bring healthcare costs down. If we want to get to affordability, and you ask that very important question, and for me that is the crux of all of this. Health insurance and healthcare isn't any good if it's not affordable to you. It has to be affordable. Affordability and universality are the two criteria that you find at healthcare systems throughout the world. And we tend to fall down on the jobs in the affordability area. And we need to be creative and find ways to make healthcare affordable. In some cases, we have to understand that for low income and vulnerable populations, we're going to need to subsidize them. And we have to accept that as a country.
So Access Health's shop, which was for the small businesses, that was set up to allow small employers to purchase affordable health care for their employees. But low participation leaves the citizens paying a $32 million assessment per year to subsidize the program. So what would low enrollment in the SHOP program, or would low enrollment in the SHOP program be the same for the public option? And why do you believe employees are more likely to participate in a public option?
I think that James Michaud, who's the CEO of Access Health, would be the first person to admit that they have not done the best job of marketing the small group options that are available on Access Health. And I know that from meeting with him a couple weeks ago, I think that they're going to make a concerted effort to do that. I think that most individuals, if you polled them, would probably not know that that's even a benefit for them. And so I think we think a lot about that in the context of what we're talking about and how we would have to really dedicate a lot of energy around figuring out ways to market this to folks and make sure that they knew that that was an option for them. And I think that it's very different than Charter Oak, which I think at the apex of its existence, maybe 12,000 people total were enrolled in it. That's not our goal. Our goal is to enroll hundreds of thousands of people. And yes, that scares some people, and that's what we're going to have a conversation about. But the goal is to have it become something that is synonymous with an option for those that are small employers or small employees.
Lynn, do you have any ideas on this, and what happened with SHOP?
I believe in the beginning it was under-resourced from the start as far as how they were able to fund the marketing and the outreach for the program. But I also just think there's a big sticking point with small business owners and whether or not they feel like they really have the capacity to offer coverage to their employees. And one of the things that we've heard is that people would like to be able to do that. It would help. It would help keep good employees. What they're finding is still what was happening before the ACA was that they were recruiting and training staff, and then when staff could get a job that provide better coverage options for them, they might leave for that security. And I think it's a tough road. I think that part of the small business population is still going to be exploring as individuals in the marketplace. And I think if the small group market isn't working as well as it should be, that the other nice feature about this public option discussion is that we can be talking about better ways more choices for individuals who aren't getting it through their employer and need to go into the marketplace for coverage. My son is one of those people. He's 29 years old. He works at a nonprofit in New Haven that is very small. And several of the employees there get coverage through other programs. And the idea of getting into the marketplace for 3 employees doesn't make sense for them. So he got a promotion. He earns not much more money than what you need to qualify for subsidies. And at age 29, with school loans and everything else, he's paying $350 a month for his premium with a $6,000 deductible. And that's virtually making healthcare unusable for him. Except for a well visit, what 29-year-old is going to go access care for specialty care or anything else because they don't want to end up, they don't have the $6,000 to pay out of pocket. So I think whether it's small business or individuals, they both face, fierce challenges, and we need to step up and offer more choices. I don't know what the easy fix is to the small business shop on the exchange. I would posit that the exchange needs to be a lot more creative and aggressive than they have been.
So we're going to be wrapping up here. Does anybody have anything, any last words they want to add, or no?
I would just say thank you, Christine, for convening this conversation, and I think it's one that is on the minds of a lot of people in the state, and I think this is a conversation that will continue for the session. Appreciate you pulling us together.
And I guess we will have to wait until March 7th to find out what the insurance committee is going to be proposing. But I want to thank everybody for coming, and I'd like to remind you to, if you're not already on our email list, sign up for our email list on our webpage. Oh, and it's in the back. You can sign up if you would like to sign up in person. You can do that in the back of the room. And also, we are a member-supported site, so if you find it in your heart to help us continue, do so before apparently Governor Lamont puts a tax on newspaper subscriptions. So, and thank you very much to our panelists.